Hello and welcome back to ACCRAC. I'm Jed Wolpaw, and I am thrilled to have back some returning guests who listeners will recognize as having been on the show multiple times before. They provided such fabulous updates and education in the past about all things cardiovascular anesthesia related, and I'm thrilled to have them back today to talk about the Impella device and how we can think about using that and what the updates are on that device. And so I'm really excited to learn from them and for them to be able to teach all of us. I have with me Dr. Joseph Cody, who works as a cardiac anesthesiologist in the community setting. He's passionate about both cardiac and general anesthesia, enjoys working with residents and SRNAs and ensuring quality and safety at his institution. And both Joe and Mike, who's our second guest, know each other because, as you may remember, back when Joe was Mike's fellow on this show, Joe was Mike's fellow many years ago. And Joe has no disclosures to make. Now, Dr. Mike Essandoh, everyone will remember, is a cardiothoracic anesthesiology attending at Ohio State. He's also a full professor of cardiovascular anesthesiology and assistant dean for graduate medical education. He does a variety of clinical consulting, and he wants to disclose that he's a clinical consultant for Biomed Johnson & Johnson MedTech, the company that makes the Impella. And so while obviously he does that work, he's going to give us some great information today, and you can take that as you will. Gentlemen, thrilled to have you with us on the show.
Thanks for having us.
Thanks for having us, Jed. Yeah.
All right, Joe, let's start with you and tell us first, why did you think it was a good idea to do an update here? I think we've touched on the Impella in the past in other episodes, but there's some updates, and so you thought it'd be a good idea to maybe revisit and do a little more detail. Tell us why, and then give us the background about cardiogenic shock, which I assume is the main indication for this device.
Yeah, so I thought it was important. I think we had done a similar podcast a few years back, and I thought it was important to make this update because it's kind of been a controversial thing. Do you do a balloon pump? Do you do an Impella? And finally, in 2025, American Heart and ACC published some updated guidelines on acute coronary syndrome, and they actually changed the recommendation of placing an Impella to a grade 3. So it's a pretty big change that I notice in the guidelines, and I think that it's slowly catching up in the clinical field too. But there's still kind of controversial. But we're definitely moving more towards the Impella and further from the balloon pump.
And Joe, maybe just for folks who don't know, what does that mean that they changed the recommendation to a grade 3? What does that mean?
So basically, like a grade 3 basically shows there's no benefit to doing it. Is basically what the authors who come up with the guidelines are saying.
And that is for which device that they made that they changed it to a grade 3?
For the balloon pump. For the balloon pump.
Okay, good. I just wanted to make sure that's what we're saying. So the balloon pump, which maybe was thought to be much more recommended or used much more often, now a grade 3, meaning there's not really evidence to use it.
Yeah, and it's still controversial. I mean, the practice hasn't totally changed. But it seems to be how things are going. Things are for cardiogenic shock.
All right. So speaking of cardiogenic shock, take us through the important things that we need to know when we're thinking about that. And obviously, we could do a whole podcast on cardiogenic shock, but let's just talk about the key things to know when we're thinking about the Impella device.
Yeah. So if someone's in cardiogenic shock, some basic hypotensive, they're cool and clammy. The lactate's probably going up. You'll probably get a echocardiogram, see what's going on there. And you basically have to do your workup to establish that it is cardiogenic shock. And then after you've established this cardiogenic shock, the question is why. Setting it's from ischemia, so an acute MI or that sort of thing. And then there are lots of other reasons. Uncontrolled atrial fib is pretty common. Valvular disease is pretty common. But so after you establish it is cardiogenic shock, then you need to go and now you need to treat that. You're certainly not going to go to the balloon pump right away. But if you do your basic medical therapy, you try to fix what's going on, and then it's not working, then you would talk about the Impella or the balloon pump, but typically the Impella these days.
Great. All right. So, Mike, why don't you talk to us about non-mechanical management of cardiogenic shock? What are we going to try first?
Oh, perfect. And, Joe, thanks for introducing this important topic and for organizing this podcast. So the main thing, Jed, is over the years, we haven't had great direction as to how to diagnose and treat cardiogenic shock. Most of the parameters we've used have all been a bit antiquated. So around 2019, the Society of Cardiovascular Angiography and Imaging, they did some seminal work trying to classify cardiogenic shock itself. And they came up with 5 classifications, very simplistic, A through E, where patients who are SCAI Class A are pre-cardiogenic shock. Patients who are Class B are hypotensive and are close to being in shock. Class C is the quintessential cardiogenic shock patients who are hypotensive, have elevated lactic acid from hypoperfusion. And they also brought up a new parameter, which is cardiac power output, which is a product of your cardiac output times your mean arterial pressure divided by 451. And if your CPO or cardiac power output is less than 0.6, you are in profound cardiogenic shock. And they also have added pulmonary artery pulsatility index to also identify if there's a right ventricular component. So the classification goes from A to E, with A being pre-shock, B being, escalation to shock, and then C to E are the patients that require most attention. And there's also a new direction to managing these patients. You have to take, so before you even go into treatment, you want to classify, is this patient is A or C or E? And the goal is to prevent escalation to the worst stages of cardiogenic shock. And secondly, you want to identify if they have univentricular dominant cardiogenic shock versus biventricular, and that would help you with your escalation strategy. So if it's a left ventricular dominant shock, the treatment strategy should be different versus a right ventricular dominant cardiogenic shock versus a biventricular. And that's when we go deeper into mechanical circulatory support for cardiogenic shock. So the initial management, as Joe stated, these patients are hypotensive. So it starts off with a hemodynamic derangement, mostly hypotension from some cardiac insult, which leads to a low cardiac output, low cardiac index. Some patients may be called clammy because they're either vasodilated or vasoconstricted. So the initial workup should be a multitude of imaging. Echocardiography can play a role. Placing a PA catheter so you can calculate your pulmonary artery pulsatility index. Having an index of your wedge pressure if you advance the swan to get your wedge or your left atrial pressure, or you can use your PA diastolic pressure as a surrogate. Then you can progress to if it's an acute myocardial infarction cardiogenic shock versus non-acute myocardial infarction cardiogenic shock. If it's an acute myocardial, obviously they have to go to the cath lab so they can reperfuse that distribution of the coronary circulation. So the shock management has to start with initially for the SCAI stages A to C, it's inotropes, which also will be determined by the dominance of the shock. So it can be epinephrine, dobutamine, Mirinone, and then you can use vasopressors, can be vasopressin or epinephrine to support your systemic vascular resistance. And the goal is to restore circulation. But there are 3 components as you're treating cardiogenic shock that you, the clinician, should think about. Because the pump has failed and it's not supporting the body, all the end organs. So you want to restore circulation, which is providing, adequate delivery of oxygen to the cells. But most importantly, we also want to rest and restore the heart. And that would involve the new concept of unloading, which involves taking the pressure and the volume out of the left ventricle so you can improve blood flow to the myocardium. And then myocardial perfusion becomes the third aspect of the equation. So when you start with inotropes and vasopressors, if your lactic acid keeps increasing and you become tachycardic and, your left ventricular diastolic volumes and pressures keep increasing, the patient's chest radiograph shows pulmonary edema, it means the patient's state of shock is increasing from like a C to a D or E. So you have to be very quick to measure how your treatment is impacting the patient's clinical state and then escalate to mechanical circulatory support if the need is there.
Fabulous. All right. So let's talk about how that happens. Let's say that we have escalated into those D and E range of cardiogenic shock, and we think, medical management's not working. What does mechanical circulatory support look like? How do we decide between a balloon pump, Impella, ECMO, a VAD? What happens there?
Excellent. That's a fantastic question. This is something I've struggled with after doing this for many years because oftentimes it was hard to decide what device. So I'll start off by sharing a few randomized clinical trials that the listeners can, read at their own time. And that would guide them to understand why some of these devices don't work. So the first, it's only 4 trials, so I'm not going to go deep into research. The first is the IACCRAC trial. And most of these trials, all 4 trials, are based on patients with acute myocardial infarction, cardiogenic shock. So they took 26 patients and divided them equally between the use of an intra-aortic balloon pump, which provides counterpulsation in diastole and it deflates in systole. And the other 12 patients had the Impella 2.5, which is an older pump. It's been decommissioned, but it provided up to 2 to 2.5 liters of maximum flow support. And essentially what they discovered was that it didn't provide any mortality benefit. However, there was a slight improvement in cardiac index in the patients that received the Impella compared to the intra-aortic balloon pump. Because the intra-aortic balloon pump fundamentally would increase your cardiac index by maybe half a liter. So if you have a patient that's in profound cardiogenic shock, that may not be enough.
And Mike, let me interrupt you real quick. I realize we should probably just say what is an Impella. So it sits where and what does it do?
Fantastic. So the Impella is a microaxial pump. It's a catheter-based pump, which is implanted in a retrograde fashion. It can there are different platforms. There is and I wouldn't talk about the 2.5 because it's decommissioned. There's a CP, which is implanted by a cardiologist, a retrograde fashion through the femoral artery. And it goes through the, retrograde through the aorta into the left ventricle. The inflow, which expels blood from the left ventricle, sits for the CP about 3 centimeters from the aortic valve and the 5 centimeters from the aortic valve. And the outflow is in the ascending aorta. So it's simplistically, it's like having a little straw that takes blood from a failing ventricle and deposits it in the ascending aorta. So it takes the volume and the pressure away from the left ventricle, and then it essentially deposits it in the ascending aorta. So it improves coronary perfusion, unloads, takes the pressure and volume off the left ventricle, so it fosters coronary perfusion and myocardial recovery.
Great. Okay. Perfect. Just wanted to get that out there.
Perfect. The second trial was the IABP Shock 2 trial, which was in 2012. It was a larger study, 600 patients, also acute myocardial infarction, cardiogenic shock. So they compared the patients that received the balloon pump to patients that received standard medical therapy. So the balloon pump group of patients received the balloon pump in addition to medical therapy, whether it was vasopressors, inotropes, or diuretics, whatever the team felt was, the goal for that patient. Whereas the medical therapy group obviously received just medical therapy. It was quite fascinating that the mortality was even. The balloon pump mortality was 40% and the medical therapy was 40%. So really large study, multi-center, did not show any benefit in acute myocardial infarction, cardiogenic shock. And now let's fast forward to 2023, because since balloon pumps didn't seem to provide enough unloading and enough circulatory support, there was a thought that if we use VA ECMO in the peripheral configuration, it would support circulation. But we, not to, say that there wasn't a deeper thinking about this study, but it wasn't realized that as you administer blood in the peripheral configuration, so they put a cannula in the femoral vein in a patient with acute myocardial infarction, cardiogenic shock, and then they would drain the blood into an ECMO circuit and return it in a retrograde fashion through the femoral artery into the ascending aorta. 420 patients evenly distributed between the VA ECMO patients who received VA ECMO and medical therapy, and then 208 patients received just medical therapy. And the discovery was about even. 48% of the ECMO patients died in 30 days, and 49% in the medical therapy died in 30 days. So it was no benefit comparing peripheral VA ECMO, not central VA ECMO, peripheral. So there was, but on the downside, the ECMO patients, because of the sizes of the cannula and the need to anticoagulate them, had higher bleeding risk, more vascular injury, strokes, and other complications.
Hey there, ACCRACers. I want to tell you about a CME conference that I will be speaking at in the new year from February 28th to March 7th, 2026. It is an amazing conference. It is the Holiday Seminars Conference in Maui at the Hyatt Regency Maui Resort and Spa. I have been there before. I've spoken at this before, and it is incredible. The family, the Smith family that puts this on, they really do an incredible job. It's going to be some amazing speakers. It's a beautiful hotel and an opportunity to really enjoy Hawaii and Maui, and especially at a time when Maui is trying to recover from the wildfires. They're really going all out to try to make the tourist experience an amazing one. So I think this is a great year to come, and the conference is going to be incredible. You're going to hear from amazing speakers who are going to go over really, really high-yield topics. I highly, highly recommend signing up for this. You can go to holidayseminars.com and click on the Maui link, and you can register there. You can use CME money. It is going to be amazing. So I hope I will get a chance to see you there. It'll be a ton of fun.
So in 2024, the most pivotal trial in cardiogenic shock treatment is the Danger Shock trial. The name actually doesn't go with the way the trial was designed. So Danger is just, they used that, phrase because it was Denmark, Germany, and then they added the United Kingdom at the end of the trial. 10-year study, and they compared the Impella CP, which is a femorally implanted Impella, in addition to medical therapy against patients who receive medical therapy only in the context of an acute myocardial infarction cardiogenic shock. It was about 360 patients and evenly divided, and then they discovered a mortality rate. This is the only trial that actually analyzed mortality in 6 months. All the other studies were 30 days. So in 6 months, the mortality rate was 46% in the Impella CP group versus 59% in the medical therapy group. And the number needed to treat to prevent one death in the Impella group was 8. So this is the trial that has really changed. Though it was the basis for the revision of the new 2025 ACC guidelines that Joe referred to.
Great. So it sounds like balloon pump compared to medical therapy, no benefit. ECMO compared to medical therapy, no benefit. But Impella compared to medical therapy did have this quite impressive benefit.
Yes, and another thing I want to share with this was it was also, so the Impella platforms have different capabilities. So the Impella CP, which is implanted in the femoral configuration, can give you a maximum of 4 liters support. Whereas there's a surgical Impella, which is implanted through the axillary artery into the left ventricle, can give you up to 5.5 liters support. So even though these patients receive the Impella CP in the femoral configuration, I think most of them may not have even received the magnitude of the support that they needed, because they just designed it where you get an Impella CP or not. But what we practice, especially at the highest data, is we quantify the hemodynamic support that the patient needs before we prescribe the mechanical circulatory support. So if I take, a phenomenal athlete like LeBron James, whose cardiac output may be 6 liters and they put an Impella CP in him, he would have heart failure. So I always recommend to my fellows and residents to calculate the needs of the patient. You can use a simple, we all know that a cardiac index of 2.2 is the minimum that we strive for. And cardiac output times body surface area, a cardiac index of 2.2, I hope I didn't misspeak, is what we strive for. So if you multiply a patient's body surface area by 2.2, that should give you an index cardiac output. And then you can use that index to identify what mechanical circulatory support device would best suit their hemodynamics.
Great. So Joe mentioned that the balloon pump is now a class 3 recommendation. What about the Impella?
Fantastic. Yes. So the balloon pump is class 3. As Joe stated, eloquently, it means it does not provide any benefit survival wise. And also let me contextualize this. This ACC guideline was framed around acute myocardial infarction cardiogenic shock. It doesn't really, they didn't use the patients that you and I take care of in the operating setting, but I think we can still take some of this information and apply it. So the Impella CP, which is a low, I would say it's not the highest, regarding support, that has been moved up to a class 2A recommendation, meaning that it can reduce mortality. So I guess we can make some inferences that if that can, provide some mortality benefit, then if you use the 5.5, that may even be more superior and may prevent, when you go into the danger shock, there were a few complications that I should share. Some of the patients had bleeding complications because you have to anticoagulate them for the PCI and to keep the pump in. There were some vascular injury because also, you're going through the femoral artery. And then patients, and these were mostly in the Impella arm, needed renal replacement therapy. So there are complications that come with this new technology, so it has to be used thoughtfully.
Yeah. Stay with us. We'll be right back. Hey, folks, the holidays sneak up fast, but it's not too early to get your shopping done and actually have fun with it. Uncommon Goods makes holiday shopping stress-free and joyful with thousands of one-of-a-kind gifts you can't find anywhere else. Uncommon Goods looks for products that are high quality, unique, and often handmade or made in the U.S. Many are crafted by independent artists and small businesses, and because they're made in small batches, the best finds can sell out fast. I found this beautiful, handmade, customizable gardener's basket for my wife that she absolutely loved. It wasn't just that it was helpful for gardening, it also made her feel that she was helping an independently owned small business, and she said it was the perfect gift. Uncommon Goods has something for everyone. From moms and dads to kids and teens, from book lovers, history buffs, diehard football fans to foodies, mixologists, and avid gardeners, you'll find thousands of new gift ideas that you won't find anywhere else. And with every purchase you make at Uncommon Goods, they give back $1 to a nonprofit partner of your choice. They've donated more than $3 million to date. So, shop early, have fun, cross some names off your list today. To get 15% off your next gift, go to uncommongoods.com/ACCRAC. That's uncommongoods.com/ACCRAC for 15% off. Don't miss out on this limited time offer. Uncommon Goods, we're all out of the ordinary. Hey folks, fall always feels like a reset. Between back to school, busier routines, and shorter days, finding time to cook can be tough. That's why I love Factor. Their chef-prepped, dietitian-approved meals make it easy to stay on track and enjoy something comforting and delicious no matter how hectic the season gets. My kids think Factor tastes like restaurant food, and it really does. Even my 2 younger daughters, who are very picky eaters, are loving every meal we get from Factor. Some favorites are the chicken tikka masala and premium proteins like salmon and shrimp that come at no extra cost. And with 65 different meal options, you've got GLP-1 friendly meals packed with protein and healthy fats, and savory global flavors like the new Asian-inspired meals influenced by China, Thailand, and more. 97% of customers say Factor helped them live a healthier life, and the amazing thing is that it's not just healthy, but super fast and incredibly tasty. I wouldn't have believed it until I tried it. Get Factor if you want all the flavor and none of the fuss. Get started at factormeals.com/ACCRAC50 off and use code ACCRAC50 off to get 50% off your first box plus free breakfast for a year. That's code ACCRAC50 off at factormeals.com/ACCRAC50 off to get 50% off plus free breakfast for an entire year. Hey, ACCRACers, we are thrilled to have as a returning sponsor the one and only TrueLearn Smart Banks. I've used TrueLearn for my residents for years, and it is hands down the best smart bank out there. The questions are excellent, and the answers have clear explanations that break down why each choice is correct or incorrect. I love that it's customizable, so you can target weak areas or take a longer or shorter practice exam anytime. Their metrics are great, and their mobile app lets you study on the go. We use their ITE, basic, and advanced smart banks for our residents, each with 1,000 plus questions, realistic visuals and graphs, and even a calculator that mimics what you have on the exam. Our residents love it and get great results. TrueLearn even has a CME Smart Bank where you can get AMA, PRA, Category 1 credits after you finish training, and an adult cardiac anesthesiology Smart Bank as well. And now they have a fabulous flashcard product, which you can check out, and I highly recommend it. Go to TrueLearn.com and use code ACCRAC to get $25 off residency exams, USMLE, and Comlex Smart Bank subscriptions of 90 days or longer, and up to 20% off other healthcare exam subscriptions. We rely on TrueLearn for our test prep, and I recommend you do the same. TrueLearn.com and use code ACCRAC. Hey, folks, you know what can make a real difference in your quality of life at work? Comfortable scrubs. And not just any scrubs, but FIGS scrubs. They're made for awesome humans and I think can truly make a difference for healthcare workers. These are scrubs that have our needs in mind. They're durable, antimicrobial, and super comfortable, which matters when you're 10 hours into your shift. I love my FIGS, and let me tell you, my wife, a pediatrician, loves hers too. She wears them to work every day, as do so many of the doctors and nurses I work with. It doesn't matter if you're a dentist, a nurse practitioner, an anesthesiologist like me, or even a medical student starting out. Investing in a couple pairs of FIGS is totally worth it. We are partnering with FIGS to get you 15% off your first purchase when you use code FIGSRX at wearfigs.com. FIGS goes beyond scrubs too. They've got shoes, underscrubs, and even jackets that will make the ever-present hospital AC seem like a thing of the past. And they come in a wide range of colors that will let your personality shine through. Try FIGS today by going to wearfigs.com and get 15% off your first order when you enter code FIGSRX at checkout. That's 15% off when you enter code FIGSRX. All right, and we're back. Okay. Great. So Class 2A for the Impella CP as opposed to Class 3 for the Bloom Pump now. Okay. And then data still to come on the 5.5.
Yes. Data still to come. Yes.
Great. Let's talk about how these Impellas are placed. You mentioned that the CP goes transfemoral. Joe, do you want to talk to us a little bit about the different placements of the CP versus the 5.5 and some of the pros and cons?
CP is like a quick fix Band-Aid. So it's placed in the cath lab. Anesthesia is typically not involved. The cardiologist will place it through the femoral vein, artery, and they use a combination of fluoroscopy to cross the aortic valve, and then typically just bedside TTE to confirm that the inlet and outlet of the CP are positioned kind of like a short-term thing. So if they're having a STEMI, they just need the short-term support till the PCI is completed or till they go for CABG. If they're undergoing like a high-risk PCI, and there's going to be points when the cardiologist is intervening on to get them through that. So for those like short time periods, the CP is perfect. If you need something longer, you'd probably bring them to the OR and upgrade them to the Impella 5.5.
Great. So let's talk about that. How's that placed? What are some of the pros and cons of that?
So the Impella 5.5, it typically needs general anesthesia. The patient is brought back to the OR. They're safely put to sleep. If they're not, and for these patients, I mean, they're pretty sick. So you need really good access. A-line, inotrope should be primed and ready, if not already going, as they're going off to sleep. After the patient is asleep, surgeon will do usually a 10 millimeter graft, and then either the surgeon themselves or the cardiologist will use a combination of fluoro and with the anesthesiologist guiding with TE2 to safely place that 5.5 through the aortic valve. So that's great for like an injury, and they need time for their heart to either recover, or either they may need a long-term LVAD or a transplant. So it's a great way to buy time. They can stay in by guidelines for up to 2 weeks to recover, or the patient comes up with a durable plan.
Great. Okay. So anything that if people are doing the anesthesia for these folks, anything they need to keep in mind in terms of how to manage them?
Yeah. So like probably the scariest part for me is the induction. I make sure they have a art line prior to going off to sleep. Inotropes are ready. And then after they're asleep, things to keep in mind is anticoagulation. So it's important from a couple standpoints. One, was this patient on something prior to coming to the hospital that's cause a bleeding problem? So many keep that in mind, because you don't have time to wait for these patients for that to wash out. And two, for the case itself, they just need a little bit of heparin as the surgeon is sewing on the graft, because he has a clamp on the axillary artery. Other than that, you just want to maintain perfusion the best that you can, hemoglobin, acid-base status, all the things that you think about for a normal cardiac patient. Just these patients are a little bit sicker typically.
Okay, great. Mike, let's talk about post-operatively. Although also it occurred to me to ask, you mentioned earlier, I think that, it's important to think about the left and the right ventricle and what's failing. So we've been talking about an Impella that offloads the LV. What do you do if there is a patient who has either biventricular failure or primarily RV failure? Can you use an Impella for that? How does that work? Okay.
Thank you. Another great question. So I'll just give a little bit of, I'll add a little more before I address, that aspect. So there is another initiative. It was from the Henry Ford Group. It was the National Cardiogenic Shock Initiative. And that predicated the Society of Cardiovascular Angiography and Imaging's classification of cardiogenic shock. And what they discovered is if you have a patient in cardiogenic shock who has maybe a SCI class A or B, if they are on greater than 2 inotropes and their lactate level is greater than 4, and if you compound that by a cardiac power output, which the equation is mean arterial pressure times your cardiac output, divided by 451, if it's less than 0.6, they have a greater than 60% mortality, anywhere from 50 to 60% mortality. So it becomes very critical that we really identify these cardiogenic shock patients quickly, monitor what the treatments are, see if our treatment is effective. Because if you start, maybe 2 or 3 inotropes, and then, and also emphasize the need to place a PA catheter. I know that the Swan-Ganz catheter was, getting out of favor, but this really emphasizes the need to put a PA catheter in right away so you can measure your cardiac power output. So if I have a cardiac power output that's 0.6, my lactate is, let's say, 10, I'm on epi and maybe Mirinone, and then I check in an hour or two and my cardiac power output is now 0.4, and my lactate is 20. It means that your inotropes and vasopressors are not working. So you need to rapidly escalate to a mechanical circulatory support. The reason the right is always forgotten is most of these studies, once again, are acute myocardial infarction, cardiogenic shock. But in the operating room, we're dealing with post-cardiotomy, low cardiac output syndrome or cardiogenic shock. And we have to think about the right, because the Impella, even if you escalate into an Impella, the device can work only if it receives quote unquote left ventricular preload. So we have to make sure the right ventricle is working equally. So if a patient comes to you on, let's say, an Impella CP, or it's escalated to an Impella 5.5, It's critical to monitor the pulmonary artery pulsatility index, make sure there's good urine output, so there's no congestion of the kidneys, there's no congestion of the liver, and your lactic acid is not trending upwards. If it's trending upwards, quick echocardiography to determine the function, maybe RV, EF, fractional rate change, TAPSE, whatever parameter you want to use, and you want to support that with your pulmonary artery pulsatility index, which is the ratio of your pulmonary artery pulse pressure, the PA systolic minus diastolic divided by your right atrial pressure. And if your PAPI gets close anywhere from maybe 2 to 1 based on the reference you're using, now it just indicates that you have a biventricular problem, and your left ventricular device may actually create a suction event because it's working too hard, but it has a limited left ventricular preload. So options for supporting the right ventricle in this context, there's an Impella RP Flex, which is an Impella for the right ventricle. So you end up creating a bipella where the Impella RP Flex is implanted through the right IJ, and it essentially takes blood from the right atrium, bypasses the right ventricle, and it just deposits it in the pulmonary artery. So you end up with a right ventricular support. Another strategy is the Protect Dual cannula. It's also inserted in a similar fashion through the right IJ to provide right ventricular support. And if both devices still are not providing great enough support, then the escalation may be to veno-arterial ECMO, which, through the femoral configuration, we have to, have that understanding from the ECLS shock trial that it doesn't improve mortality because it would restore circulation. But as blood is coming in the retrograde fashion, that 4 to 6 liters of blood actually increases the work that the left ventricle has to do to empty whatever volume is in it at that point in time. So you can then, if you had the Impella in place, you can use it to unload, to take the pressure and volume out of the left ventricle, and then slowly, as you uncouple the left ventricle from, the aortic blood pressure, with restoration of your circulation and unloading of the left ventricle, the patient's ventricle may recover quickly, and then you de-escalate by taking the ECMO out, and then slowly reload that left ventricle with the Impella 5.5. So that's where the ECPella or ECMella strategy comes into place.
Okay, interesting. So ECMO and Impella. So so you do have some options for the RV, Impella over there, Impella in the LV if you need it. Let me ask you, is there ever a time when you would opt for a balloon pump over an Impella, or no? That's done. We're out of that world.
Oh, yeah, excellent. So I think we first have to take that moment to, classify the patient's need. So if I have a cardiac output need, which is 2.2 times the BSA, and it's maybe 4 liters, and the patient's hemodynamics, let's say it's a post-CABG, and the patient's myocardial function is not great. If I have a swan and the wedge pressure or the PA diastolic is maybe anywhere from 10 to 12, it doesn't seem to be too much of an LV congestion. If the surgeon thinks that we may get some benefit by improving coronary perfusion with a balloon pump, then it's not a bad strategy. So the balloon pump is not, I wouldn't say it's out of commission. It was basically in acute myocardial cardiogenic shock patients, the pump function has deteriorated to the point that you may get half a liter with a balloon pump. So if the patient's needs are 3, 4, 5 liters, it's not going to solve your issue. But if you need a pump that would just counterpulse and provide coronary perfusion, then the balloon has a role. So the balloon still has a role, but in selected patients, but not for cardiogenic shock.
Great. All right. So we could obviously do an entire episode just on the ICU care of patients with cardiogenic shock. We're not going to do that. But as someone who takes care of these patients in the OR, any advice, Mike, for people in the ICU to keep in mind when caring for these patients post-op?
Yeah, excellent. So when these patients would, in the surgical room, you will see more of the 5.5. When they come to the ICU, it's important to trend your biomarkers of perfusion, because the 3 arms, we want to foster myocardial recovery. So you want to make sure that there's optimally great circulation. When you put the Impella 5.5 in and you activate it, it causes the pressure and volume in the left ventricle to reduce. So you end up with a narrowing of your pulse pressure, but the MAP would be high. that means that the ventricle is resting. You don't need to escalate your inotropes to get a pressure of 120/80. So a high MAP, and also the 5.5 gives you a surrogate because it has optical, sensors in the left ventricular cavity. It does give you an idea of the left ventricular and diastolic pressure, and you can also use your PA diastolic as a surrogate of your LVEDP. So if the device migrates into the left ventricle, it would end up causing recirculation. And as it recirculates, your mean arterial pressure would drop, and your PA diastolic and LVEDP would increase. So when you see any abrupt changes in the hemodynamics of the patient, lactic increasing, chest radiograph shows congestion, please get an echocardiogram and make sure that the Impella is sitting, within 5 centimeters. And that 5 centimeters is not prescriptive from the inlet to the aortic valve. It's not prescriptive because it's dependent on the size of the patient's LV cavity. So you get an echo, make sure that at least the inlet is in the LV cavity and the outflow is in the, ascending aorta. So you don't get suction events, you don't get hemolysis, and then you also, which would end up triggering ventricular, arrhythmias. So, imaging is critical. Abiomed recommends daily, echocardiograms, transthoracic echocardiograms. It's not as feasible. I think if the pump's working well, the patient's doing well, you can ambulate them because it's in the axillary configuration. So you can ambulate them. A lot of these patients that have pulmonary, there's the whole notion that, their lungs are not working. The lungs are not working because the ventricle is congested, atrium's congested, the lungs full of blood. Once you start unloading them, the lungs will be fine, so you can extubate them quickly, and you can also mobilize them so that they don't get deconditioned. The main challenge comes when you're trying to wean patients off these pumps. In the standard ECLS patients with VA ECMO, in either the central or peripheral configuration, we always would, bring an echo to the patient's bedside or in the operating room, turn the flows all the way down to maybe 1 or 2 liters, look on echo to make sure the ventricle is not acutely failing, and then make that, I would say, abrupt decision to de-escalate and take the cannulus out. I think that's not a good strategy, but we don't have any other option because you cannot turn your VA ECMO to maybe half a liter. The risk of vascular complications is too high. The Impella, since it works from a performance level all the way to 9, you can slowly reload the ventricle because the ventricle gets, as it's recovering, it's also deconditioned. So I can go from P8 to P6, P4, sit at P2 for a day. So you slowly work the muscles back into condition before you de-escalate the Impella. So the ability, as Joe alluded to, that you can keep the Impella 5.5 for 2 weeks gives us options that we never had before.
Okay, that's great. Now, just want to go back a second. If you have that situation you mentioned where the device is migrated into the LV and you now have this reentry circuit is just getting its own blood and pumping it right back to itself, what do you do? Is that a rush to the operating room?
No. So it depends on, yes, excellent question. It depends on the configuration, how it looks. If it's, you can rotate it, but echo guidance is very critical. So if it's facing, like if it's just migrated in where the inlet is against the wall of the interventricular septum, you can, have echo, right, point of care echocardiography and just pull it, the surgeons, because it's coming out of the axillary, and it's in the graft, so it's sterile, so they can pull it a bit without having to go in and do a full operation to reposition it. So you can reposition it, but it's very critical for the ICU folks to monitor it. And it has a screen where it shows the aortic pressure, left ventricular pressure, and a motor current. So whenever it migrates, you can see that it's migrated, and the patient's condition would change, drastically.
Yeah, fabulous. Okay, this is great. Anything that we didn't cover that either of you want to point out before we move on? Yeah, Mike.
No, I mean it's just a overwhelming topic. I think if you don't do it every day, we're trying to talk about this in about 45 minutes, and there's just so much to talk about. But I mean, I think the biggest take home is it's a great tool that buys patients. Even there are great outcomes from this, and there are not so great outcomes, but it's a great tool that buys people time to either recover or to come up with some kind of a decision. So I think that's the biggest thing. I think there's a lot more trials coming out. The danger trial, that's kind of the big one people are talking about. I think it's so interesting that they only looked at the CP. I mean, I'm sure there's a trial going on that's going to take a look at the 5.5, and I would guess that the data is going to look even better with the 5.5 versus CP, just because it gives so much more support. So, that's something down the road to look at. But, I think we've really come a long way in cardiogenic shock, but we have a long way to go.
Great. Mike,
yeah, Joe's absolutely correct. I think one of the, and Jed, I know I come on this courtesy of Joe. I've been on this platform, and what you're doing is fantastic for all the entire anesthesia community. One of the things that people always assume is that these cases come to just the tertiary, quaternary centers. But now we have the hub and spoke approach, right? So if you're a small hospital in Maryland, maybe an hour from Hopkins, if a patient comes in cardiogenic, has an acute myocardial infarction, they have a cardiogenic shock, episode, they will do a protected PCI, which is where they put an Impella in, because there's this trial called it's protected. I'm just blanking. Navin Kapoor and his group and Tufts are leading this. It's called a STEMI DTU, STEMI door to unload, before they actually do the PCI. And the signal that they are seeing is that if somebody comes with an MI, we've always been trained to door to balloon, door to opening that culprit vessel. But now they're actually seeing that when the patient comes in, if you take the volume out of the left ventricle, provide circulation, there is enough collaterals that feeds that section before you actually target, take the thrombus out and stent that segment. So the door to unloading and the door to balloon, which, the STEMI DTU trial would solve this, dilemma, is showing that unloading patients with such a pump improves survival and improves outcomes. So we will see small hospitals using these pumps. And then after they put the pumps in, if it's an acute myocardial infarction, they're not going to send the patient to a tertiary center because it takes maybe 2 days and the ventricle recovers. So if the patient develops some ischemic complication to the gut, to the legs, or arms, they will come to your operating room. So you don't have to be a cardiac anesthesiologist to manage this pump. But listening to your podcast would provide a lot of experience. It will provide some information that they can use to manage these pumps, because a pump, it depends on afterload. It requires, LV preload. And it's predicated on how the right ventricle is working. And on top of that, when the pump starts working, we as, clinicians still have to manage the metabolic state and make sure we have optimal systemic vascular resistance to perfuse the organ. So my take home is, it's a fantastic pump. Obviously, I personally have experienced it in my patients who, survive. We have to use it thoughtfully, because if you're in a low scale of shock, like a SCAI stage A or B, placing an Impella in is a little bit overkill, because the complications of limb ischemia, thrombosis, strokes, and renal replacement, that danger shock clearly, discovered. We have to balance that with the benefits that it does, provide our patients.
Fabulous. All right, guys, this is great. Lots of great stuff. As Joe said, I mean, this is just brushing the surface, but at least it's a little bit. People can delve in more to the literature. We'll put some good references in the show notes. Let's turn to the part of our show where we make random recommendations. Mike, what do you have to recommend that people check out?
Oh, I like this new show. It's on Netflix. It's about the Dallas Cowboys, the way Jerry Jones built that empire when they won their 3 Super Bowls, and it's been forever since they did anything innovative. But I think it's a great series, and when you watch it, you see how he came from nothing to become. The team is worth $9 billion. So I think it's something that may motivate us anesthesiologists to maybe become innovators, to figure out something so we can move to the next level. But I think it's a really good show.
Awesome. All right. Is it called Dallas Cowboys, or what's it called?
Oh, I don't remember the title off the top of my head.
All right, well, that's okay. We'll look it up and put it in the show notes. All right, Joe, how about you?
So I have a book. It's called the Truth Machine, the Blockchain and the Future of Everything. It's by Michael Casey and Paul Vigna, and it goes through blockchain technology is really going to be a big part of the future, and it doesn't talk about just one. It's not about Bitcoin. It's not about Ethereum. It's not focused on one cryptocurrency. It's more focused on the background of blockchain and how cryptocurrency got started and the potential roles for blockchain technology. So it's I think it's going to be something really big in the future. Pitch is to learn about some blockchain technology and the implications it may have in the future. Fabulous.
All right, I'm going to recommend a show called The Last of Us. I think it's on HBO Max. It is, I'll say right up front, it's one of the most violent shows I've ever seen. It is a post-apocalyptic zombie show, which normally I wouldn't like, but we'd heard good things, and so my wife and I started watching it. And if you can get past the violence, it is actually quite well done and interesting. And we're kind of halfway through the second season now, and definitely finding it entertaining. All right, guys, thanks so much for coming back on the show.
Thank you, Jed.
Thanks. We appreciate the opportunity, Jed. Till the next time.
All right. Hopefully you got as much out of that as I did. That was really fantastic. Let us know what you thought. Go to the website, ACCRAC.com, where you can leave a comment. Others can learn from what you have to say. If you are a fan of the show, you can follow us. We're on Twitter. We are on Facebook. We are on Reddit. And we are on Instagram. I'm at Jay Wolpaw on Twitter, and we're at ACCRAC Podcast. And you can find us on all those other platforms as well. If you are a fan of the show, please consider going to Apple Podcasts or wherever you get your podcasts and leaving a comment and a rating. It really helps others find the show. If you'd like to support the making of the show, please consider going to patreon.com/ACCRAC. That's patreon.com/ACCRAC, where you can become a patron of the show. Even if it's just $1 or $2 that you pledge, it makes a big difference, and we really appreciate it. You can also make donations anytime by going to paypal.me/ACCRAC. or looking up Jay Wolpaw on Venmo. Thank you so much to those who have already made donations and become patrons. We really appreciate it. Thanks, as always, to our fantastic ACCRAC crew. Sonia Amanat is our tech lead. Taylor Duggan, William Mao, and Rachel Furman are our production assistants and social media managers. Thanks so much for all you do. Our original ACCRAC music is by Dr. Dennis Quo. You can check out his website at studymusicproject.com. All right, that is it for today for the ACCRAC podcast. I'm Jed Wolpaw. Thanks for listening. Remember, what you're doing out there every day is really important and valued.